Hey guys, welcome to another video. Today we'll be talking about folic acid inhibitors, also known as anti-folate drugs. So we already know that folic acid is used for DNA, RNA and protein synthesis, and bacteria can synthesize it itself. It does so by taking pteridine, PABA and glutamate. And the enzyme folate synthase converts these three into folic acid. Folic acid can further be converted into tetrahydrofolate using the enzyme DHFR. So folic acid inhibitors simply inhibit these enzymes that are here, and you can see some of the drugs that I have written here. So for folate synthase inhibitors, we use sulfonamide, dapsone and PAS. For DHFR inhibitors, we use trimethoprim, proguanil, pyrimethamine. And we also use methotrexate. Methotrexate is also an anti-cancer drug, and when we are using methotrexate, folinic acid is given as THF because it causes vitamin B9 deficiency and that can cause anemia. So all drugs individually are bacteriostatic, but combination of the drugs in A and B are bactericidal, and that's why we use it like that. So one of the questions that arises is that drugs requiring folinic acid supplementation are all the drugs that inhibit your DHFR enzyme. That is trimethoprim, pyrimethamine and proguanil. All these three will require folinic acid supplementation. And folinic acid is an antidote for which anti-cancer drug? Methotrexate. DHFR inhibitors in microbes, we use trimethoprim, pyrimethamine and proguanil. For humans, we use methotrexate, and in pneumocystis, we use trimethotrexate. For methotrexate and trimethotrexate, we give folinic acid as a supplementation, and this is also known as leucovorin or citrovorin factor. Talking about bactericidal combinations, we use sequential blockage of enzymes and it causes synergism, or it is also known as supradditive effect. So what are the combinations that we use? We use sulfadoxine with pyrimethamine and folinic acid for treatment of malaria. We use sulfadiazine and pyrimethamine, which is a DOC, drug of choice, for Toxoplasma gondii. We use sulfamethoxazole and trimethoprim, and this combination is known as cotrimoxazole. Moving on, talking about cotrimoxazole, we know that we can have a simple trick, that is co over here stands for combination of trim, that is trimethoprim, and sulfamethoxazole. So that is how we get co-trim-oxazole. Okay, cotrimoxazole. It is also known as TMP or SMX, TMP SMX combination. The ratio that these two drugs individually are combined is 1:5, and the uses you can remember for cotrimoxazole using a mnemonic as pint beer cup. The capital letters are the mnemonic letters. So we can see here that P stands for pneumocystis jirovecii infection, and it is cotrimoxazole is the drug of choice for pneumonia in HIV patients. It is also known as PCP pneumonia. After P, we go into I, that is isospora and cyclospora, which causes diarrhea in HIV positive patients. Next, we have N, that is nocardia and prophylaxis in neutropenic patients. That is your cancer patients on chemotherapy. They have a symptom of neutropenia. So PIN, next is typhoid, and we use it for typhoid prophylaxis. That is not used anymore, but just for your knowledge. Then we are at B. So B for Burkholderia capacia infection. In mild cases, we use cotrimoxazole, but in severe cases, we need to get the big guns, that is your carbapenems. And the drug in carbapenems we use is meropenem. After B, we go to cup, that is C for cystitis, U for urinary tract infections, and P for prostatitis. Moving on to the next drug, that is sulfonamides. The drugs that are used can be either systemic or topical cream. There's also topical eye drops that are used and topical oral. For systemic, you have short acting, intermediate acting and long acting. In short acting, you have sulfacetamide and you have sulfadiazine and you have sulfasoxazole. Out of the three, shortest acting is sulfacetamide. Intermediate acting, there's only one drug, that is sulfamethoxazole. For your long acting, you have sulfadoxine, that is the longest acting. For topical creams, use sulfadiazine, that is your drug of choice in burns patients. You also have mafenide, that has a side effect of lactic acidosis. That is why it is not used in burns patient, because they already have anaerobic respiration going on since the skin is already burnt off, and this causes lactic acid buildup in these patients. That is why mafenide is not used in burn patients. Okay. For topical eye drops, we use silver sulfadiazine 10%. This is used for the treatment of keratitis, that is protection of corneal ulcers as well as glaucoma. Both these drugs are used for that. The second drug is sulfacetamide. For topical oral drugs that are not absorbed, we use sulfasalazine, and they only act on surface of intestine or GIT since they are not being absorbed. So sulfasalazine, if you can imagine that if it's staying in the lumen itself, then it can be used for the treatment of ulcerative colitis or IBD, and it is also used for the treatment of rheumatoid arthritis. The mechanism of action for most of these drugs is that they inhibit the dihydropteridine synthase enzyme, and the structure is similar to PABA. Hence, they are competitive inhibitors of PABA. We need to note that is a very high yield point that these drugs are not effective in pus or abscess infection because these have a high amounts of PABA, purines, and thymidine, and therefore competitive inhibition, the property is reduced. Going on to the pharmacokinetics, they are part of the shift drugs and they undergo acetylation. We need to note that slow acetylators will show toxicity, and this causes a side effect known as DLE, that is drug induced lupus erythematosus, and it is excreted in urine, therefore dependent on your renal function. Therefore, they can be contraindicated in renal failure. The side effects of sulfonamides can be remembered by a mnemonic called as rash ABC. R simply stands for rashes, that is your sulfa allergy, and it can lead to SJS, that is your Steven Johnson syndrome. A for aplastic anemia, and bone marrow suppression occurs due to the sulfa allergy. S for slow acetylators, they'll show SLE or DLE. H for hemolysis in G6PD deficiency patients, therefore it is contraindicated in such patients. Rash is done. Moving on to ABC. A is altered taste. B for bilirubin displacement from albumin, therefore it is contraindicated in neonates and third trimester of pregnancy. And for C, it is crystalluria. We can reduce the risk by alkalization of urine. Therefore, least risk drug is sulfasalazine. Now, disorders of hematopoietic system are acute hemolytic anemia, agranulocytosis, as well as aplastic anemia. Also, is a small diagram to represent sulfonamide acting. So what happens is that sulfonamide displaces the albumin from bilirubin, which causes bilirubin increase, and this bilirubin can cross the blood-brain barrier. Therefore, it enters the brain of neonates. It can cause encephalopathy, and this is known as kernicterus. Moving on to the next drugs, trimethoprim. It is an DHFR inhibitor. It causes side effects of megaloblastic anemia and nephrotoxicity. For megaloblastic anemia treatment, you give folinic acid supplementation. We already saw that earlier. For nephrotoxicity, it causes damage to the collecting duct. It is known as renal tubular acidosis type 4. In this, the potassium is not excreted in urine, which causes hyperkalemia. It can further affect your CVS. Therapeutic uses of these drugs include nocardiosis, in which sulfasalazine or sulfadiazine is given, which is 6 to 8 grams daily, and it's continued for several months even after manifestations have been controlled. The second disease is trachoma and inclusion conjunctivitis. For that, you give sulfacetamide sodium, that is a topical. And for IBD, you give sulfasalazine and mesalazine. Thank you.